Hey Sydney, hey Angie.
Right. Mike, can you give me a little bit of a agenda for today? I'm just wondering uh, wh- when I'll be putting my slides up and what the rest of the meeting generally looks like.
Yeah, so I just have a few slides that I'll start off with, and there's a
Okay.
blank slide that has your name on it, so that'll be
Okay.
your cue. So, and
Okay.
I'll talk and I'll hand it over to you to introduce
Okay.
you.
Okay. And I'm gonna probably go through my slides pretty quickly. I know I've sent, it looks like a lot, but I can get through it pretty quickly. And then is it okay if I sign off after I present?
Yeah.
Okay, because I have to run to campus. We have our symposium today. So, um, but yeah, I'll stick around if people have some questions, but um, I may not stay for the whole time.
No, that's fine.
Okay.
All right, good morning, everybody. It's a little past 9, so we'll go ahead and get started. So thank you for joining today's update for the longevity study on this webinar. My name is Mike Malakamati. I'm one of the researchers that works with the longevity study with the Banner Some Health Research Institute. I'm actually located at Banner Alzheimer's Institute, but I do a lot of work with the Banner Some Health Research Institute with the longevity study. I also have an appointment with the University of Arizona College of Medicine, where I co-teach a course there. Um, So today I just want to provide all of you with an update on kind of where we are with the study, what we're doing, and kind of where we're going to what we plan on doing over the next year or so. And I have a couple of colleagues who will be giving some short presentations about the work and collaborations they're doing with us in the longevity study. And then toward the end, I will answer some questions that had been submitted through email and then answer any questions anyone might have as we go through it. So, just before we get started, if you could make sure you're on mute before we start, just so we don't have any extra noise coming in as our presenters are talking. So, just a basic history of the longevity study. This study was started in 2007 by doctors Walter Neary and David Kuhn. And originally, the intent of the study was to understand the social, psychological, and emotional factors that contribute to successful aging. However, over the years, we've kept certain components of that, but we've started to evolve the study to include measures of cognition, physical function, and more so now we're moving towards the addition of blood and brain imaging biomarkers, some of which you'll hear about here in a moment. So our team is headed up by our principal investigator, Dr. Ali Atri, who unfortunately could not be on the call today. He is at a conference in San Diego right now. David Kuhn, professor at ASU, is also the co-investigator for our study. Angie Kiramoto heads up is a director of the study and oversees the day-to-day operations of it. Farah Sheikh and Lupita Martinez are faces of the study. You've probably interacted with them on the phone, email, or in person when you come in for your visits. And then, of course, I am part of the study as well. And I do want to acknowledge our wonderful volunteers, many of whom you get to interact with when you come in for your study visits. We have a really fantastic team of volunteers, and I'm really grateful for their contributions and what they do. So I just want to make sure all of them are acknowledged in this list here. So what are we actually kind of looking at and studying right now with the longevity study? So one of the things that we are addressing is how subjective memory changes correlate with performance on cognitive tests and other self-reported mood questionnaires. The topic of what we call subjective memory complaints or subjective cognitive complaints is a very big topic in the area of aging and cognitive changes right now. And so we're trying to also be a part of that and address that by looking to see if there are certain things that we have in our study that may correlate to whether somebody, feels like they're, not doing as well cognitively, or whether they are, whether they're noticing the age-related changes a little bit more than others. More recently, we're starting to include blood biomarkers of different proteins that we can correlate with these measures of cognition and quality of life. And more specifically, with these blood biomarkers, we want to use these to be able to understand, what it is that helps people maintain a high level of cognition, even in the presence of age-related and sometimes disease-related changes in the brain. Right. So to talk about the blood biomarkers, I wanted to have Dr. Nick Ashton, the director of our biomarker program, talk today, but he is also at the same conference in San Diego right now and could not be on the call today. But I have this video that he has available that really kind of gives a nice overview of the biomarkers we're using in the longevity study. So I'll play this video for a couple of minutes, and you'll hear Dr. Ashton talk about some very basic aspects of biomarkers, kind of what they do, what we use them for, so that you get a better understanding of what it is that we're actually looking at with the blood that we take at each visit.
Dr. Malika Mahdi.
Yeah, just saw that the audio is not working. Is the audio better now, or is it still not on?
It's still not on.
All right. Well, my apologies to all of you for that, but I'll give a brief overview of the biomarkers that we're looking at. So, the biomarkers themselves, what we are looking at is actually a large panel of different proteins, about 120 or so, that are available with the system that Dr. Ashton uses in his lab. And what that allows us to do is to look at things like inflammation and some very basic biomarkers of proteins that we think are associated with Alzheimer's disease and also with aging. And really, as I said before, what we're looking to see is, what is it about these markers that we can look at and see what is helping people to be successful in aging, and not just looking at things that are associated with decline and disease, but rather what is actually helping people stay healthy and stay cognitively active in later years. So there'll be more to come on the biomarker analyses that we're doing. I can tell you that we are actively analyzing the data that we have so far from the select group of samples that we've had. And I can tell you right now that there are analyses that have been carried out, and we are currently writing abstracts for presentations that will be done at conferences up in the coming year. So we're very excited about that, and we're really excited to have this really very valuable piece that we've been able to add to the study. So the next thing I'll do is I will turn it over to our other collaborator, Dr. Sydney Schaefer from ASU. Those of you who have come and do the in-person visits, you've probably done what we call the Bean Board for a few times now. So I'll let Dr. Schaefer talk about her work and her work with the Bean Board and why her rationale for doing that and what she's doing with that data. So Sydney, I will turn it over to you now.
Okay, hi everyone. Thanks for having me. First, you can, I guess, Mike, can you nod if you can hear me and you can see my slides? Okay, excellent. Okay, well, I'm going to just take a few minutes of your time. Mike asked me to present a little bit about the kind of really silly motor test that we have you do at the end of your visits sometimes, that I think has been affectionately called the Bean Board. So I wanted to give a little bit of background into kind of what it is, why we are excited to collect it, and really wanted to share some results that have come directly from your participation. And so I just wanted to say, before I get going, a huge, huge, huge thank you to you all, including Mike and Angie, and for all of you for your willingness to come with us on this journey on establishing the Bean Board. And if any of you are marketing specialists and have a better name for it, definitely let us know. But really trying to establish it as a performance-based test for monitoring dementia risk. And here are just some updates from 2025. Oh, whoops. Okay, so this is probably a crowd that's familiar with the term dementia and dementia risk, but I really just for the purposes of just kind of the background today, really when we think about ways that we can monitor the sort of acceleration or progression towards dementia, there are types of cognitive assessments that you are, I know, familiar with, ones that you have done in the longevity study, the Montreal Cognitive Assessment and the Mini Mental Status Exam. You may have also participated in other studies or with your primary care provider, or maybe someone sent you a link to a clock drawing test. These are all really quick and easy ways that clinicians can evaluate sort of cognition and various aspects of cognition, sort of that thinking. But a really important aspect also to understanding progression towards dementia in populations or certain cohorts are really these functional assessments that really evaluate the integration of cognition into daily life or just daily functioning. And this is important because dementia really is cognitive impairment that is severe enough now to affect one's daily functioning. So remembering to take your medication, remembering to turn the stove off, being able to navigate, driving to run your errands. So those are, yes, they involve cognition, but they are really now the integration of cognition into daily functioning. And there are some other measures that do that. Other measures that you're familiar with, like the clinical dementia rating and the everyday cognition measure. Um, and so something that these daily functioning measures have in common are they oftentimes involve subjective reporting from what the kind of field calls an informant, like a spouse or an adult child, a roommate, a close friend. And I understand that the version of the ECOG that you participate in, the questions are asked directly to you. But for people who are experiencing cognitive decline, we really want to get insight from that kind of collateral source. So the everyday cognition can be and often is measured or collected also from an informant in other contexts. And so it's really important to get information from an informant, but not everybody has one. And some recent statistics show that almost over 25% of older adults in the United States are considered solo agers, meaning they don't have an informant for a number of reasons. And even if someone may have an informant, they might be an adult child that lives in another state and maybe can't necessarily provide really reliable, despite their best efforts, information about sort of how well an individual's integrating their cognition into daily life. And so, really, what we've been trying to do is come up with a solution that allows people to have their daily functioning evaluated objectively without the need for an informant. And so that's what we're trying to do with the Bean Board. And so broadly, this is what we do in our research. And Mike has been a longtime collaborator in this effort. And something that through the advent and the inclusion of these plasma biomarkers, the blood-based biomarkers that Mike talked about, we can now look at how performance on this test is associated with daily functioning, as well as its specificity to some of the pathologies, as Mike mentioned, that might be associated with eventual Alzheimer's disease and dementia associated with it. So this is like version 2.0 of the Bean board that we kind of have developed in my lab over the years. And what I really wanted to just sort of pull back the curtain on is how the heck did we land on this? Because it seems so kind of random, but it really came from a lot of background research that I did earlier in my career as a postdoc. And in 2011, I was working as a postdoctoral fellow at Washington University in St. Louis. And my training had really been in recovery of motor function following stroke. And I really developed this task as something that people could do many, many, many times to kind of rewire the brain following stroke in a sort of a functional task that kind of reflects a task in daily living. And what we found over the course of that research was cognitive impairment that was either premorbid to one stroke or comorbid from the stroke really impacted how much a person learned on this task. And that then took me in this direction of trying to understand what aspects of cognition that this task really relied on. And I know that you've all done it before, so I don't need to go into what the task is or what it looks like. But here's just a summary of some of our findings to date, many of which Mike has been a part of. And if you have any questions or would like a copy of any of the papers for any of these findings, I'm happy to send them to either Angie or Mike and have them distribute them to you, or you can reach out to me directly. And so we've done a lot of what we might call validation work in this area to really establish this as an objective, brief, easy to administer tool that can evaluate cognition daily functioning in individuals, particularly those that don't have an informant. So I just want to say that that's what the findings that we've had so far, but really what the impact of this knowledge and that stems directly from your participation are kind of, I think, two major things. The first is there's been a real need and a real push from some federal agencies and agencies globally to come up with other ways or other outcome measures for some of these new drug trials that are coming out for things like lecanemab, aducanumab, and all of these anti-amyloid drugs that are starting to show some modest efficacy on reducing the amyloid in the brain. But it's really important that we also monitor, does it help reduce symptoms? Does it improve people's quality of life? And so there's been a big push to have functional outcome measures in addition to biological outcome measures in these drug trials. And so there this has potential to serve as a possible functional outcome measure in drug trials. And also outside of clinical trial research, just an easy and quick and simple way for primary care providers and other healthcare providers outside of specialist care just have a quick and easy way to monitor their patients for like, yeah, you're doing good this year. Let's come back and look at your performance next year, just to sort of make sure that everything still looks good. And also for triaging patients, if someone is starting to show some cognitive concerns, as you may know, wait times for dementia specialists are incredibly long and even longer depending on where you live in the United States. And so right now, there's really no way for primary care providers to sort of triage patients based on kind of urgency. And so this is also potentially a way that primary care providers could do that. And this is really important because the Alzheimer's Association continues to identify and advocate that primary care providers are really at the front lines of dementia care. It doesn't start when someone sees a specialist, but it's really at the sort of primary care level. And we need to provide tools to those providers to empower them in that role. So I'm going to finish my kind of not so brief now presentation on some three directions of now how are we taking this out into the real world, kind of beyond the lab. And I want to talk about this new project that really came about a year ago. I was at ASU graduation sitting, and I just randomly sat next to another faculty member that I'd never met before. And we started talking about our work. And this is Dr. Heather Ross, and she's in the College of Nursing. And she's been doing a lot of work with trying to do some dementia screening in homeless shelters within the larger sort of Phoenix metropolitan area. And there's a lot of very sort of not so great statistics around aging and homelessness and dementia. And there really is not a lot of information out there right now on how to quantify it and sort of how to manage it. And I bring this up because some of those gold standard measures for evaluating daily functioning really can't and don't apply to unhoused populations because they don't really have a reliable informant, and their daily activities don't necessarily reflect those that are often asked in those questions. And so this is a possible application for the Bean Board that we have. And so you may or may not know this, but one of the only homeless shelters for older adults exists right here in Phoenix. And the Haven, which is an old or converted Super 8 motel at I-17 and Northern, I think. You might see it off the freeway if you drive up that way. But basically, Dr. Ross has done a lot of advocacy work within the Haven and the larger Central Arizona shelter system. And so earlier this year, in September 26th and 27th, we took a team of undergraduate students, biomedical engineering students, and nursing students to the Haven with the permission of the Haven to just sort of do a proof of concept are individuals willing to do this, and what do their scores look like? And so what we're doing right now is comparing their performance to a normative housed sample, and that would be you all, and really trying to evaluate the feasibility, acceptability, and then kind of using this to help stratify downstream plans that social workers can do with individuals who are at risk or maybe suggestive of dementia. And then another kind of like really big swing of work that we're doing is with the Chamane Health and Life History Project. This is a multi-site study that's actually based out of University of Southern California, but Dr. Ben Trumbull, who's shown on the top right, is a researcher here at Arizona State University. And this has been kind of like a long ongoing project that focuses on this Amazonian horticulturalist group deep in the rainforests of Bolivia. And the reason that this has been such an interest to many researchers is the prevalence of dementia and mild cognitive impairment in this population is incredibly low. And so they're exploring what might be some protective risk factors associated with this population. And because our task is so simple to administer, there's not necessarily a language or educational component to it. We have taken it into the deep into the rainforest and have integrated it into their annual data collections. And you have seen the plastic cup version coming into the longevity study. And when we took that down to Bolivia, there was one of the participants thought we could do better. And so he actually carved a wooden version of it, and you can see it in action right there. And so to date, we have about 500 individuals who have participated, and we have data from them. And so again, we're hoping to compare scores from this population to, a normative sample, a healthy aging sample like you. And we have some other research questions that we want to address. And last, I just want to say thank you for not only helping the research that we're doing, but also there's a number of junior scientists at ASU, either assistant professors or graduate students, that are also benefiting from the work that we're doing. And so I wanted to say thank you on their behalf. And the last thing, and Mike and Angie wanted me to share this briefly because they find it very exciting. And so my work has all focused on, at the translational work, we're collecting and running studies with, you know, adult participants. But there's some research questions that are really hard to answer with those methodologies because studying a disease like Alzheimer's disease, you have to follow individuals for years or decades. And you hope that they don't ever develop the symptoms associated with Alzheimer's disease. But in order to study the disease process, we can leverage animal models that are genetically predisposed or genetically hardwired to develop the symptoms and the pathology associated with Alzheimer's disease. And so this is a new project that we presented at the Arizona Alzheimer's Consortium earlier this year. And we're utilizing a well-established transgenic animal model of this rat model that basically develops Alzheimer's disease in the matter of months. And we created a rat version of the bean board that doesn't involve having them use spoons or anything like that. But a lot of the characteristics or behavioral characteristics of the bean task that we've been able to really quantify, we've tried to implement that into a design that works for animals. And we have measured their performance on that test, as well as a really established cognitive test for for animals called the Morris Water Maze. And what we're finding is that the kind of motor test, the animal version of the bean board, is more sensitive to earlier decline in that compared to sort of the classic kind of cognitive test. And so this is really compelling evidence that um, something like our tests could really be used clinically to pick up early signs of progression towards dementia in ways that these were more traditional cognitive tests maybe can't yet in these early stages. So I know I just said a lot, but it's because we have a lot going on, and it really is in a huge, huge part thanks to you all and your commitment to this work. So I just wanted to say thank you for all your support over the years. And I'm happy to, take questions, or Mike can solicit questions from you all later, and he can send them to me, and I can respond to them via email. I don't want to take up any more of your time, but I thank you for letting me be here, and thank you for letting me give you an update.
Thank you so much, Sydney. We appreciate you giving the update and taking the time to talk to us today. I know you have to get going, so if you need to log off, please do so. And if there are any questions that are directed to you, I will forward those to you and get those back
Wonderful.
to everybody.
Okay, thank you so much for letting me be here, and thank
Of
you
course.
again.
Thank you. All right, so I'll talk a little bit about some of the things that we are doing right now and then hoping to do here in the next year. So right now, as I mentioned, we are analyzing the biomarker data that we recently acquired. We have actually several students who are working with us to do these analyses. And as I mentioned, several of them are going to be presented at upcoming conferences in 2026. One thing that we are also trying to do is obtain funding that would allow us to do MRIs for those who are able and willing. Wouldn't necessarily be for everybody. We know that there are some people who cannot do MRIs or simply don't want to for different reasons. But this is something that we're trying to implement and make available to individuals. This would be for research purposes and not necessarily for anything diagnostic. We are continuing our collaboration with a PhD student at New Mexico State University. Her name is Casey Bauer. I know some of you who have done a computer-based test where we send you a link via email and you have done it from home. This is a study that Casey is carrying out as part of her graduate work. And so she's very thankful to all of you for being able to do that. And certainly we will continue to gather data and collect data for for that project as well. One very exciting piece of news that I have, and will hopefully be more exciting in the coming year, is that we've submitted a grant to the National Institute on Aging to support the longevity study. And what we were hoping to focus on is looking at a protein called TDP-43 and how it might be associated with age-related changes in the brain and age-related changes in cognition. So TDP-43 by itself is a protein that is independent of Alzheimer's disease and other kinds of dementia, but we do know that it does have a pretty profound effect on cognition at higher levels. So what we want to understand is, to what extent does this protein TDP-43, how much does it contribute to the changes that we see in aging? So the last thing I just want to say before we take questions and have some discussion is that for myself and on behalf of the team, we're very, very thankful to all of you for your contributions, for the time and energy that you give to us. You all are, as hopefully as you've seen here, you all are making very significant and invaluable contributions to the science of aging to help us understand, how we can help everybody, age better. And really and truly, you are the ones who make science happen at the Banner Sun Health Research Institute. And I can't express enough how grateful I am and the team is for what you all are willing to do with us each year. And we're very grateful for it and just want to make sure we express that to all of you. All right, so I did receive a couple of questions via email that I'll start with first, and then I will open it up to other questions that we might have. So one of the first questions that we got was regarding Prevagen. So I know that there's always been a lot of discussion uh, about Prevagen and this supplement and whether it's actually effective or not. So as most of you probably saw in the very first slide, I have a PhD next to my name and not MD. So there's not a lot I have a very strict line that I cannot cross when talking about medications and treatments. What I can say is that Prevagen is considered to be a nutritional supplement. So it has not been officially, cleared by the FDA to be a treatment for memory or something that would improve memory. So although it is, marketed as something that is, something that can improve memory, the the claims that they are making have not been fully, tested to the degree that the FDA would, normally want for a medication. So there are some clinical studies that have been done with Prevagen, and mostly what I've heard is, anecdotal evidence from people, and I will say that it's been, 50-50. There are some people who, swear that they have a really good effect from it, and then others who have not have had no improvement whatsoever after taking Prevagen. So that's the best I can say about that. The next question was about the effect of statins or cholesterol-lowering drugs on dementia. So this has been a very controversial and interesting topic over the last several years. So for the most part, I will say I'll first talk about the positive aspect of this is that for the last several years, say 10 to 15 years, there's been pretty consistent evidence that individuals who are taking statin drugs actually have a lower risk of developing Alzheimer's disease. So there's something about being on a statin that appears to protect people from developing Alzheimer's disease. Now, one of the things that has also come up in recent years that's been quite negative and has kind of given some statin drugs a bad reputation is that there are some individuals who actually do experience very severe cognitive problems once they go on a statin. And what we found is that it's a very small portion of individuals who are prescribed statins who experience this, but nonetheless, the people who do experience it is a very profound deterioration of their cognition that we see. And usually, when they come off the statin, their cognition usually doesn't. It's not a permanent change. It usually comes back and goes back to normal. So there is one aspect of what we're trying to figure out, and I know that there are other, investigators across the country trying to determine sort of what are the biological factors that are predisposing this, this certain group of individuals to have this bad cognitive reaction to statins. It's still something that we don't quite understand just yet as to why that actually happens. But if you do just a Google search of, statins and dementia or statins and Alzheimer's disease, you'll definitely find studies that indicate that statins actually seem to have a protective effect for Alzheimer's disease. And the next question we got was regarding specific medications in the development of dementia, and specifically the use of hormone replacement therapy for menopausal women. There is a lot of evidence, or not evidence, there is a great deal of research that's being done in this area. There are some indications that hormone replacement therapy may actually increase the risk of Alzheimer's disease in women. And then there are others that indicate a decreased risk. What the difference seems to be is when women start the hormone replacement therapy and what age they do it at. So usually what we see is that when women start at an earlier age, that they tend to be the ones who are protected from getting Alzheimer's disease or have a lower risk, whereas those who are prescribed it later in life tend to have the higher risk of developing Alzheimer's disease. So that's the general tendency that we see right now. There's still no definitive statement, regarding, whether hormone replacement therapy does or does not increase the risk of Alzheimer's disease. But certainly it is something that, it has, been in the forefront for quite a while now, and is still something that is being looked at. The next question we got is regarding the use of GLP-1 agonists or semaglutide drugs, famously the ones that are prescribed, had originally been prescribed to treat type 2 diabetes, but are now famously used for weight loss. There is some evidence coming out now that there actually may be some other beneficial effects of these GLP-1 drugs in terms of overall health and possibly cognition. The evidence is still very, very preliminary regarding anything outside of weight loss and type 2 diabetes for the GLP-1 drugs. But certainly there is a lot of there is a lot of rationale for looking at these drugs in terms of their effect on cognition and aging, because one thing that we do know is that type 2 diabetes is a significant risk factor for developing Alzheimer's disease. So there's a good possibility that there's something about the biological effect of GLP-1s that, may actually be protective and help people decrease their risk of Alzheimer's disease. But that's not something we're, certain of right now, and that hopefully in the next, coming years, we'll get a better handle on. So those were the questions I received via email. I'm very happy to take any questions you all may have. If you are brave enough to unmute your mic and speak directly to us, I'm very happy to do that. One of the main reasons we do this webinar is to allow you all to, understand, what your contributions are, and and to answer the question of, well, what do you do with all this data that you collect from me each year? So this is really our effort to help answer that question. So if you all have any questions that you'd like answered, I'm very happy to entertain those right now.
Hey, Mike, they can also put their questions in the chat as well.
Yes.
If you're more comfortable sending it via chat, that's fine.
Yes, thank you, Angie.
No problem. I don't hear any.
And as I was going to say, as we're waiting for some questions too, I just want to let everybody know that we are recording this webinar today. So if you, once I am able to download it and then post it onto a YouTube page that I run, that will make the link available to all of you, and you can go back and watch this later. Or if you know of individuals who would be interested in seeing this webinar, you can direct that link to them as well. This will be, open access, publicly available, no restrictions or anything like that. So question is, what if someone drops out of the program? Is all the data wasted? No, it is definitely not. So we know that, we over the years of this study, we've had people who have discontinued for a variety of reasons, be it moving, health reasons, what have you. The data that we collect, whether it's 1, 2, or 5 or 7 years, we are grateful for, and we are still able to use and utilize in the analyses that we do. So definitely, there's for our purposes, there's no such thing as wasted data or wasted time.
Good question, Rosemary. We were looking forward to having you on today.
And what's the main connection between longevity and the brain and body? Well, there's probably many different answers to that question. So there doesn't seem to be one main connection, but rather, it's the confluence of a lot of different factors. Whether it's genetics, lifestyle, health, things like that. Let's see. Does significant life trauma, such as abuse, loss of significant others, increase the risk of dementia? This I'm not particularly sure of. So one thing that we do know is that depression can often be a harbinger for coming Alzheimer's disease or the onset of dementia. But certainly, we know that, even just outside of having, a dementia syndrome, is that, things like depression, anxiety, and other mood problems, those can have an impact on cognition as well, that sometimes makes it look like Alzheimer's disease, but is not. Meant the connection between the Banner studies and the two different buildings. So Rosemary, I think you might be referring to the connection between the longevity study and the brain and body donation program. Is that correct? Okay, so the longevity study and the brain and body donation program are two separate studies unto themselves. We do have individuals who are enrolled in both, and we love that. We welcome that. Um, so one thing that we are, the connection that we have right now is more sort of administrative and logistic. So the individuals in the brain and body donation program, our staff in that program rather, they do a lot of help with us in storing and analyzing the blood samples that we take. And Angie, maybe you can speak to other aspects of how the brain and body donation program is connected to longevity, but really and truly they are two separate studies.
Yes, and I'm happy to do that, Mike. So, for those that are in both studies, the one of the huge benefits for being in the brain and body donation program and also longevity is we share data and we share information. And so, if you are in longevity and you are also enrolled in brain and body, you do not have to do that optional assessment with the longevity team. You will do that through your brain and body donation assessments every year. And then for your blood biomarker samples that you do donate to us, we will only draw for BPDP, and they will share part of their sample to longevity, so you don't have to get poked twice. So we try to make it a benefit to be duly enrolled, and share the information amongst the studies. So that's one of the benefits and how they're related.
Hello, can you hear me?
Yes.
Okay. Hi. I had a very interesting discussion with the young lady who was doing my testing over the last couple of weeks. And one of the things I commented on, this was actually in the brain and body thing. It was a story. They tell you a story and you have to repeat the story. And
Mhm.
it's a story about the soccer ball and the dogs. And I said to her, you don't have to read me the story. I know it out of my head already. Why don't you change the story? She said, that's the whole point. You know it out of your head, but there are a lot of people who come in who don't remember it from last year. And that's what we're looking at, whether you're actually remembering from your experience last year or whether you're having to hear the story again. I think I'm a terrible waste of time in your programs. I spend so much time asking questions and having discussions with the people who are working with me. I use up more time than I'm supposed to do.
So
But
Rosemary,
interesting.
so what I can tell you is that you are definitely not wasting time. So the first 12 years of my career, I spent doing that testing. Six of it was with the brain and body donation program.
Yeah.
And there's actually some practical reasons, why the tests don't change from year to year. Um, the main thing is that it's very hard to develop new cognitive tests. And when you develop a new cognitive test, you have to go through a very long series of validation studies to, basically say, yes, it is proper and, good enough to use in the real world. And there just aren't that many tests that do exactly that. So one of the things is that it's very hard to develop alternate versions that are equal in difficulty. So there are some cases where we do have alternate versions of tests where we give one version one year, one version the next year, and we alternate them. But in those cases, those are tests that a lot of money was invested in developing them and getting those different versions validated. So um, that's one big reason why you see the same tests from year to year is because it's expensive to get new ones.
You've just brought up something very relevant to something you said earlier. You're applying for a grant to do the MRIs and so on and so forth. Has this program been affected in any way or significantly by what's going on with the reduction in grants being given by government and so on? Has it affected us?
So that's a good question.
Okay, thanks.
Yeah, and it's yeah. So I myself and others, we when we get asked this question, we have to really reserve ourselves because it's been a very emotional and touchy issue for a lot of us. I can tell you that I've had colleagues whose entire labs have been shut down from having their grants just summarily pulled, and that's it. Um, so there's this right now, what I can say is there's a lot of uncertainty. We just don't know exactly how things are going to work, you know, going forward for the next few years. So what I can say is this, and this is the positive part, is that despite what you might, hear in the news with,
Drama.
drama, political divisions, and what have you, I can tell you with great certainty that in Congress at the national level, there is significant and widespread bipartisan support for aging and Alzheimer's disease research. So, regardless of what color, state that these people are representing from, uh, the work that we do and that we are all participating in is strongly supported. And year over year, we've been very fortunate to see increases in funding for Alzheimer's disease research and other related disorders. So that's something that we've been kind of leaning on. But again, the big thing is right now is just there's a very high level of uncertainty because what happens is that so to give you one example, so the government shutdown that we've just went through, one of the direct results of that was that that grant that we applied for was supposed to be reviewed in October. And because of the government shutdown, the committees that review the grants could not meet. So now that grant is being reviewed in 2 weeks. And we're hoping that we can still, if it's funded, still stay on a timeline that we had originally anticipated. But that's been the effect of the government shutdown. Now, one thing that also is a very unfortunate side effect of that is that when the Congress does not pass a budget, when they just do a continuing resolution as it is, where they just kind of kick the can and do enough just to get by, that has a very negative effect on the National Institutes on Health, because what they do is they keep their budget flat and they don't increase anything and they just leave it as it was, from the prior budget. So that makes it a lot harder for, new research to get funded. I was actually directly impacted by that by a grant that I got a couple of years ago. I was supposed to get it a year earlier than I actually did, but because the score that I got was right on the border of being funded or not, the program officer said, "Hey, you have a much better chance of just resubmitting, for this next cycle when we have more certainty with our budget." So I had to wait a year to actually get a grant that I, was, probably going to get in there. So
But
So
we
those
will
are
be
the
able to go on. When I say we, I mean all of us
yes.
in the study, you running it, us participating. It will go
Y-
on.
Right. So right now, so most of the most of the longevity study as it is right now, does not rely on federal funding.
Good.
So for right now, and I can tell you that Dr. Attree, our principal investigator, he has advocated for this study vigorously for several years now, and he really he loves the study, and he thinks it is of great value to the work that we do at Banner Research, and so he uh, continues to strongly advocate for the funding to continue for this study. So I would say as of right now, you all will not see any major changes, and there was nothing that will be affecting all of you in your participation. So for you, I would just say let us worry about the let us worry about the funding part, and you all just still be enthusiastic and still continue to come in and see us each year.
I'm actually coming in next week.
Oh, excellent, excellent.
We have one more question in the chat, Mike.
Yes. Do Amazonians in the rainforest have a longer lifespan? This study sounds very interesting. Diana, unfortunately, I don't, Dr. Schaefer would be the one to ask about that. I can direct your question to her and try and get the answer back to you through Angie, if that's okay with you.
I just think it's amazing what you
Excellent.
Any other questions or comments you all would like to bring up?
Great job, Dr. Malikamati. And thank
Oh,
you,
thank
Rosemary,
you.
for your activity. We appreciate you and Suzanne and Betty and others that joined. We really appreciate your participation and coming in every year. This is amazing and appreciate your time sharing this information with us as well. And please share that with Dr. Schaefer as well, Mike, if you don't mind.
Will do. Well, that's it for us. And again, if you all have any questions that come up, feel free to ask them when you come in for your annual visit, or you can reach out to us via phone or email. We really want to, make sure that you all, for as much as you engage with us, we want to make sure that we engage with you as well. So, never, don't hesitate to ask, and don't be a stranger to us. But other than that, I wish you all a good weekend, and I wish you all a very happy and healthy and safe holiday season coming up. And thank you all very much again for your participation.
Thank you. Bye.
Thank you.